us this opportunity to share our perspective with all of you. I want to apologize that we, other than Michael, he is the academic amongst our group. We're very practical people building a new campus, and we don't pretend to be able to bring wisdom to Geneva. We're going to bring our perspective and hopefully learn a great deal from you so we can avoid, as we say in Texas, reinventing wheels. Now, Michael introduced some Texas language, and that was howdy. The main campus of our school, which is about 100 miles away from us, our school is 36 years old, and when people meet each other on that main campus of the university, they say howdy, and that's bonjour in Geneva. We have our own language. Some people have accused us of being a bit of a cult. But our campus now is only 5 years old, and our charge as a state-funded institution is to train doctors to meet the needs of Texans. And Texas needs more doctors, we need more competent doctors, and we need caring doctors. And I come to that conclusion from being a patient. That's what I want when I'm sick, and I assume most people do. Michael reviewed the impact of the Flexner Report on American medicine. This quote comes from Dr. Peabody, a Boston physician, only 16 years after the Flexner Report. The Flexner Report married science and medical education to make medical practice in the United States more scientific. And 16 years later, he says many people are criticizing medical practice as too scientific. So this cry for more person-centered medicine is not new. Before we embark on things, we like to stop and reflect. How will we know when we have succeeded? What does success look like? We turn to a report from the U.S. Institute of Medicine, which clearly documents what we heard from Dr. Epperly. The American healthcare system is broken in many regards. People fly to the United States for tertiary care and quaternary care, but we are not very good at preventing people from needing that high-cost care. So this particular report outlined 6 characteristics of success, and you can read them. I would point out that care cannot be patient-centered if it is not safe, effective, timely, efficient, and equitable. So therefore, we must ask ourselves, what is the essence of patient-centered? And the conclusion we came to, our perspective on that essence of patient-centered, relates to compassion, not in the abstract, not as a feeling, but in reality as a behavior, compassionate behavior. So we would tell you that the goal is to turn out practitioners that can deliver scientific care, work effectively as members of interdisciplinary teams, and to deliver that care in that team context in a compassionate fashion. We believe all 3 of these components can and must be evidence-based, and that was the beginning of my discussions with Dr. Schwartz, because he is well-founded and has written a great deal on the philosophy of medicine and of personhood. And I would keep saying, but Michael, what difference does it make? How can we take that wisdom and train more humane physicians? Because if it doesn't help us to train better physicians, what's the use of it? He will probably respond later. I took this definition of compassion from Wikipedia, but we could take it from anywhere. I think we all know what we mean, even though we might choose slightly different words to describe it. I would just emphasize we're looking for compassionate behavior. The fact that you care about me doesn't matter to me if I can't perceive that you care about me. This is not a new concept. In the beginning of this presentation, I noted that Dr. Peabody complained in 1926 that doctors had become too scientific. Well, sages from both the East and the West have been imploring us to engage in compassionate behavior towards our fellow human creatures for thousands of years. I would note the bottom quotation, which points out that by being compassionate, we are not just benefiting the patient, but we are benefiting ourselves as well. 100 years, or even 60 years since the end of World War II in the United States, with a lot of money put into federal research for biomedical sciences through the NIH, we have witnessed incredible advances in our ability to diagnose and treat human disease. The advances are just mind-boggling and could not have been imagined if you lived 50 or 100 years ago. But few would argue that we've made similar progress in how effectively we care for one another. In fact, some would argue we've actually gone in the wrong direction. So this leads me to ask, why this discrepancy? How can we make so much progress in the treatment of disease and so little progress in the treatment of people with disease? And two theories occurred to me. The first was, and I was quite convinced that the first was true 4 weeks ago. The first is that the advances in the diagnosis and treatment of disease have been largely the product of a reductionist approach to science. It's yielded huge benefits, but scientific reductionism has its limits in many spheres. The laws of physics that I learned in high school are not true, and then later in college I learned that they weren't true. They were useful in understanding everyday life, but Newtonian physics fails miserably at explaining many phenomena in science. And now we have a new science emerging of chaos theory and complex systems defined by diversity, connectivity, interdependence, and adaptation. And these are systems that by definition you cannot predict the outcome without running the system in an iterative way and getting there. There is no formula that will predict the outcome of a complex system, and hence the failure of long-term weather forecasting, the failure to be able to predict the behavior of financial markets, to prevent war, and other things. So I was quite sure that our science, the tools of our science, were not adequate to understanding caring. But I changed my mind. I think that the real issue is that caring has not been a sufficient priority. As Dr. Epperly noted, medical care in the United States and in much of the developed world has become very big business, driven by the profit motive, and this profit motive has fueled the scientific discoveries that have given us better diagnosis and better treatment. So it's a model that has worked very well in one realm. The problem is the market has not placed the same value on caring and compassionate behavior, and the amount of funding that has gone into person-centered medicine or better caring or compassionate care compared to the funding that has gone into reductionistic science to make better diagnoses and better treatments is like a drop in the ocean. And if you don't fund it, if you don't make it a priority, should we be surprised that we've made little progress? So, our campus, the dean asked me, what can your campus specialize in? What can your campus do better than the other locations in our medical school? And after thinking about it and talking with some of my colleagues, I came to the conclusion that we should tackle the biggest problem in American healthcare today. Not the biggest problem of 100 years ago. 100 years ago, it was putting science and medical education together. We've succeeded over those 100 years. The biggest problem today is bringing about a healthcare system that delivers effective, timely, efficient, patient-centered medical care to all of our citizens, fixing the American healthcare system. And that's too big a problem for me to solve, or Dr. Schwartz, because we're too old. And realistically, none of our faculty is going to live long enough to solve that problem. So we decided that we would focus on training physicians with the leadership perspective and the leadership skills that some of the products of our campus might go on to contribute in significant ways to the biggest challenge of our time, fixing the American healthcare system. Toward that end, we thought about the domains for inquiry and action in person-centered medicine. And we came up with 6. There should be 7. I will get to that. It's appropriate that we start with the person. Although I think The need for research here is less than other areas because there is a large body of knowledge about the nature of personhood. Michael Schwartz has contributed to that body of knowledge. One thing we might want to do in this domain is to distill it to the essence that every surgeon, every internist, every family physician should understand about the nature of personhood to practice person-centered medicine. Next we come to the dyad. This is the fundamental unit because you cannot witness caring or compassionate behavior. I believe you cannot witness it unless you have two people interacting. A person can feel caring, but you can't see them care if there isn't someone to care for. And the major research question in this domain is how to better measure caring. And there is some progress evident in the literature. I've not done a comprehensive review. Some of you could probably speak to this quite thoroughly. But we have learned that the way we traditionally interview students for medical school with 1 or 2 interviewers is much less effective than having 8 or 10 interviewers doing very brief interviews that are highly structured, where the student is faced with a situation to which they must respond. The applicant is faced with a situation. And the responses are not right or wrong. The responses are just how that person chooses to respond to another human being in a situation. But if you have 8 or 10 observers watching how someone responds, the predictability of compassionate behavior from that individual in the future is much stronger than from 2 interviews. The third domain, the caregiver. I think this is where we have the greatest opportunity. Now, one of the fundamental questions is, are caring people born or made? And the answer is clearly yes. Both are true. There is emerging evidence about the genetic influence on behavior, including in compassionate behavior. And we know that if a baby is not held and nurtured in the first year of life, the likelihood that it'll be a less caring individual, perhaps even sociopathic, when it grows up is quite strong. But the fundamental questions here for a medical school are, how, from domain B, the dyad, how can we measure caring in this 18, 20-year-old individual who has both genes and early childhood experience? And how can we select those that are more likely to be caring healers after we finish training them? Second question, what can we do during the 4 years that they're in our care to nurture the caring skills and to have them leave our institution as more caring than when they arrived? I shudder to confess that in our private conversations, we fear that our current curriculum is actually having a counterproductive effect, that our students are more caring, more sociocentric, more interested in primary care disciplines when they are admitted to the medical school than when they leave. And we make excuses for them. They have a lot of student debt, they have to pay off their loans, therefore they need to be ophthalmologists and gastroenterologists rather than primary care doctors. But there's a lot of room for us to do better. And the third question in this domain is, what can we do in the 4 years we're working with them to instill the skills of lifelong learning and self-discipline that we will launch them on a trajectory, and with each decade they will become wiser and more caring individuals and not stay where they are when they leave our institution. The final 3, the team. Healthcare is delivered in teams, and some teams are highly effective. I think teams where people care for one another are more likely to actually care for the patient. And our organizations often do not facilitate teamwork. I spent a number of years working for the Department of Veterans Affairs in the United States, and like most hospitals, the VA system puts a team together to take care of the patient, but nobody in the team reports to the same boss. The doctor reports to the chief of medicine, the nurse reports to the chief of nursing, the clerk reports to the chief of administration, and everyone reports in a different direction. So if they become an effective team, it's because they decided to, not because the organization was designed to facilitate their being a team. Organizations, the same issues apply. I believe the behavior of the chief executive in an organization has tremendous influence over what people perceive to be as valued. If the CEO of your hospital routinely walks around to talk with patients and families and behaves in a caring way, employees notice that. They notice that caring behaviors are valued, and you're more likely to see those behaviors amongst the staff. The system really speaks to the financial incentives that were discussed earlier today. The American healthcare system has financial incentives that have succeeded in producing high-quality tertiary and quaternary care, but work against effective primary care. I apologize to Juan and the board of this organization because in retrospect, level 7 should have been the global level. And clearly, at the global level, people can gather and exchange ideas and stimulate one another to be more effective at training healthcare professionals and running healthcare organizations so as to support person-centered care. To what extent it is possible, beyond the exchange of information and education, to actually influence person-centeredness around the globe from a global level, I think is an unanswered question. But time will help us with that. So at this, I will conclude and either take a question or not based upon the direction from the organizers.